Hello, we're here with Dr. Ajay Kirtane. He's a professor of medicine at Columbia Presbyterian and director of interventional services. Dr. Kirtane, thank you so much today for giving grand rounds at the Texas Heart Institute and Baylor College of Medicine. Amazing talk about an approach to stable coronary disease, and a lot of sort of hot topics were addressed during your grand rounds. So speaking of your grand rounds, if there is sort of one main message that you want to give to individuals, especially, trainees in cardiology, about your approach to stable coronary artery disease, what would it be?
Well, first, I just wanted to thank you for having me. It's really a historical place, and to be here, to be able to give grand rounds, is a true honor. I know my parents will be proud.
Yeah.
They were here.
That's always
especially
that's the most important thing.
But, I think that the way I like to think about evidence-based medicine is based upon my training, which is essentially, I've trained in statistics and I've run clinical trials, but also I practice and take care of patients in the cath lab as well as in the clinic. And to sort of marry those two approaches together, to do it in a patient-centric way, but informed by the evidence, is kind of how I think medicine gets exciting, and it becomes a privilege to take care of patients that way. So I think the take-homes are, for every patient that comes to see me, I tend to try to break it into two categories. The first is, what are their symptoms? Are there angina symptoms? Are there not angina symptoms? How severe they are? Are they limiting to them? Do they bother the patient? That kind of thing. The second component is the prognosis. Is there a way to change their prognosis from having coronary disease? Coronary disease is a systemic disease, so it's part of an overall process. And so guideline-directed medical therapy, obviously super important. And as a specialist, I have the ability to spend time in the office talking to patients about all those things like lipid-lowering therapy, lifestyle modification, exercise, smoking cessation, et cetera. But then beyond that, for the patients that are sitting there in front of me, I want to know, is their anatomy typically, or their risk, high enough that it merits some other further investigation? And the reason I say that is because I could have two patients looking identical in front of me, one of whom has left main disease and the other of whom has an RPDA lesion. Mm-hmm. They have a vastly different prognosis. And it's, I feel, my duty to figure out which of those two cases, which of those patients is which, and then to titrate the therapies most effectively from a prognostic standpoint as well as a symptomatic one.
Just some excellent lessons there. What's your approach to sort of the diagnostic sort of methods that you prefer? I know there's been, people that have been favoring coronary CT, those that stick to stress tests. And in your case, do you feel that doing invasive approaches to establishing what the baseline coronary disease is something that may be underutilized these days?
It depends on the patient population. I think you have to make a diagnosis of coronary disease for somebody that's suggestive symptomatically. And we talked a little bit during the talk about patients with heart failure, for instance. A lot of times people don't even diagnose coronary disease. And it's important to diagnose it not just from a revascularization standpoint, but also you're going to change your guideline-directed medical therapy, your LDL target, for instance. As far as the diagnostic workup, it often depends on the patient's ultimate risk and what we're trying to accomplish. I think CT is a great approach. You can quickly figure out what the anatomy is, rule out, severe anatomy, left main 3 vessel, but you can't overreact to CT. And we talked in the discussion period about how sometimes patients get a CT result and they get called by the radiologist saying, you need a cath. Radiologists never even ask the patient if they have symptoms or not.
Right.
Massive difference in terms of that. So we have to be circumspect about it. I still use stress testing in selected cases, especially when it's not clear the extent to which patients are limited. So I think really there are a bunch of tests out there, but you need to always sit back, take a big step back and ask, what am I trying to answer here? How symptomatic the patient is, how high at risk they are, and then figure out which test is the most appropriate after that point.
Excellent. And you brought up some really interesting points today about, certain medications that we use that may not have a mortality benefit. And me, being a heart failure doctor, that's something that we think about all the time, is what medications will provide a mortality benefit. So in your practice, and based on sort of your weighing the evidence very critically, how do you balance using meds versus PCI? And then as a follow-up, speaking about looking at things critically, which you certainly do, what is your sort of recommendation for, budding cardiologists, trainees, and even the lay person out there as far as critically looking at what is in the literature and what may be published in the press? I know two separate questions.
Yeah, I mean, so first, to guideline-directed medical therapy, it's tough for patients to take a ton of medications. And so what I like to be is practical. And what I mean by that is the medicines that are going to have prognostic benefits clearly should be ascendant and should be the most important things. And the ones that don't probably are going to be, less relevant to many patients, except if they have symptoms and those medicines can take away their symptoms. Now, the problem is that so often many trainees are taught just push the beta blockers, nitrates, calcium channel blockers, ranolazine, but they're doing that at the expense of emphasizing why it's important to take the LDL down to like less than 55. That you can't do. So for me, as a rational person, if the patient's quite symptomatic and I know that I can revascularize that patient with a PCI or surgery, alleviate the symptoms, then back off on the antianginals because they don't have prognostic benefit, and really hammer home the ones that change the prognosis, diabetes medicines, hypertension medicines, statins, things like that. That's the best approach, I think, for many patients. As far as, the second question was about
critically looking at, sort of clinical trials, how you approach them, as well as sort of balancing what may be published in editorials, even in the, New York Times or, whatever media it is, with, sort of really your approach to critically looking at the data published.
I don't have profess to have a right answer to it. I just know that there are oftentimes whatever gets written, especially in the lay press, is usually a summary. And that summary also contains in it clickbait so that people can actually look at the article. So take that with a grain of salt. It's often based upon the last line of the abstract, and that might not tell the full truth. You really have to go deeper. You have to understand the methodology. Ask your mentors around you, tell me your perspective on this. Understand that the mentors may be biased as well, but the more opinions you seek, ultimately gives you some approximation of the truth. And I view that as important, with things non-medical too. I read broadly and then try to apply my own experience and then say, well, how does this fit with what I believe and know? And then be willing to adapt and change what you think you know based upon the evidence, but do it in a rational way with the best source of information that you can get. So that's kind of my advice to trainees on that.
Amazing. And I guess what we'll do is we'll end with sort of one final question is, what is your advice to sort of trainees as far as just approaching their sort of training, their career as far as cardiology is concerned?
I think number one, just keep a really open mind. I was really fortunate to have trained at multiple different institutions. And what you understand over time is there are certain commonalities. Those are just basic facts of, how to treat cardiovascular disease. And then there are other things that are institution specific, and there are other ways of doing things. If you keep an open mind, if you really try to do what's best for the patient always, not what's best for your learning or, in worst cases, your bottom line financially or anything else like that, those people who do that are misguided, I think. If you do what's best for the patient and you are able to evolve your thinking over time based on the evidence, that's how you're going to be the best physician. And frankly, in the long run, that's what keeps it fulfilling, because it really is a privilege to take care of patients, especially when we do it in a thoughtful, evidence-based way. Okay, excellent. Well, I want to thank everyone for joining us for Grand Rounds today. Dr. Kirtane, thank you for coming all the way from New York. I know it's cold in both places, but we hope you have a safe trip back, and we hope you visit us again sometime soon.